Good morning, Peter Goertz. I'm a psychiatrist. Which antidepressant should I take? Or should I take an antidepressant? They all have potential side effects. Another side of that coin is, as a psychiatrist, which antidepressant should I prescribe? So, do you want an antidepressant is one question. And there are other options, for example, psychotherapy, diet, exercise, meditation can all help potentially with depression. Yoga, Tai Chi could help. SSRI withdrawal can be a problem, even long-term for some people. Persistent sexual dysfunction can be a problem. If you, as a psychiatrist, have a patient come into your office, one aspect to consider is, what is the history of that patient? Have they tried other antidepressants? A simple situation would be, for example, a patient tried Prozac in the past, did very well, then stopped it because they're doing well, and 2 years later comes back in. Prozac may be an option since they did well on it before. Family history can be helpful if you have a patient in the office and their sister took, let's say, Zoloft with good effect. That may be an option for the patient also. If someone's pregnant or wants to get pregnant, you want to really be careful because you're not only affecting the patient, but also the baby. Zoloft in general is felt to be reasonably safe in pregnancy. If you want to prescribe an SSRI in pregnancy, you want to avoid Paxil. That has been linked with atrial septal defects in the baby and ventricular septal defects. If someone wants to breastfeed or is breastfeeding, that's another thing to consider. The medication potentially can be given to the baby by breastfeeding and may affect the baby. Weight can be an issue. So if a patient comes into your office and is concerned about weight gain, you want to avoid Remeron, which can cause weight gain. You want to avoid tricyclics. Paxil is probably the SSRI that causes, on average, the most weight gain. So those are considerations for a patient concerned about weight. If someone has bipolar disorder and is depressed, it's very tempting to want to start an antidepressant on that patient. However, you want to consider there is a risk of causing mania in the patient if you start an antidepressant in someone with bipolar disorder. Drug interactions are a concern. Prozac, for instance, affects 2D6, so inhibits 2D6. And let's say if someone's on Coumadin, you start Prozac, that may increase the serum levels significantly of the Coumadin. So it's another aspect. Bottom line, one reason I'm talking about all this today is a lot of things go into considering which antidepressant you want to take, and on the other side of the coin, which antidepressant you want to prescribe as a psychiatrist. Cardiac issues can be a concern, so you want to consider the effects on the EKG. For example, Celexa can prolong the QTC, as can Lexapro, as can tricyclics. ADHD may be something someone has in addition to depression. So the medicine then potentially to consider in someone, or the antidepressant you may want to consider in someone with depression and ADHD, might be Wellbutrin, which can have its own side effects like anxiety. Rarely it can cause seizures, especially if someone has a history of head injury, let's say, or an eating disorder. So if someone has a history of an eating disorder or a head injury or history of seizures, definitely if someone has a history of seizures or an eating disorder, you don't want to prescribe Wellbutrin. Sexual dysfunction can be an issue with antidepressants. So if someone's concerned about potential sexual dysfunction, you may want to consider prescribing Wellbutrin or Remeron. Wellbutrin, to my knowledge, does not cause sexual side effects. Remeron in general does not cause sexual side effects. So one major class of antidepressants you want to consider prescribing for depression are the SSRIs, so Prozac, Paxil, Zoloft, Celexa, Lexapro. Another class is the SNRIs, Effexor, Pristiq, Cymbalta. Another relatively new medicine for depression is Trintellix. It's in its own class. It affects serotonin in somewhat different ways from the SSRIs. And all those medicines, the SSRIs, the SNRIs, and Trintellix, can cause nausea. So you'd want to consider taking them with food, at least initially, until you're sure you can tolerate the medicine without food. And Wellbutrin is in its own class. The XL form of Wellbutrin, so Wellbutrin XL, you only want to take in the mornings because it can interfere with sleep. So that's something important to realize. You don't want to have a patient take Wellbutrin XL at bedtime. Excuse me. Remeron is another antidepressant in its own class, and that is a central presynaptic alpha-2 antagonist and also blocks 5-HT2 and 5-HT3 serotonin receptors. The part where it affects it is a central presynaptic alpha-2 antagonist is theoretically important because clonidine, an antihypertensive medicine that's also used in opiate withdrawal, clonidine is a central presynaptic alpha-2 agonist. So theoretically, Remeron could antagonize clonidine. So that's another, at least theoretical consideration. Tricyclic antidepressants are older antidepressants that are not very frequently used nowadays. They can cause significant side effects: sedation, anticholinergic side effects, orthostatic hypotension. MAOIs are also older antidepressants that are generally not prescribed very often nowadays. Something to consider, or really to emphasize with a patient when you want to prescribe an antidepressant initially, is the patient needs to take the medicine every day. It has to build up in their system, so to speak. And if at all possible, they want to try the medicine for a month and see if it works, because generally these medicines take about a month, more or less a month, to kick in, start working for the patient. Thank you.